I'm now going to be discussing interlaminar. So we saw the live surgery and we have learned also it's going to be more like a revision of the same. And when we talk about basic principles, so I think the interlaminar approach, the basic principle is what is the same, even if you use a tube, you use a UBE or you do an open surgery. Our main aim is to remove that disc fragment or decompress the dura in case of stenosis. But where does what endoscopic approach come in? So as we discussed, that the offending fragment in a disc is a disc compressing the nerve. We remove the bone, we remove the flavum to gain access to go inside. So if I am able to minimize the removal of bone, if I am able to minimize the removal of the ligamentum flavum, because they are normal anatomical structures, they are there for a reason, and if I'm able to still achieve the same amount of discectomy or decompression, then I think it's a technique which is worth it. So we'll start with a case, a 32-year-old male, right leg pain since 6 months, failed conservative. He responded to a root block, but however the pain came back. So if you see here, there was a big L5-S1 disc with a fragment which had also sequestered out. You can see that the S1 nerve is completely pushed down. Now what you first see on the MRI is, so if you see this MRI, I know this is my interlaminar space. This is the ligamentum flavum. This is my interlaminar space. So just by going through removing the ligamentum flavum, I will be able to access this region. On the top image, if you see, there is a lamina available, but because of the flexibility of the interlaminar approach, I know I will be able to get all the fragments very easily. Again, this is a young patient. Always check the X-rays. You see the size of the interlaminar window. So L5-S1 especially, you have a very big interlaminar window size. So I know that I will hardly need any kind of lamina or medial facet removal, and I'll be able to just remove this piece of disc by making a rent in the flavum. So why full endoscopic? So one is, yes, you get to do decompression, you have brilliant visualization. Because of the saline irrigation also, the dura gets pushed down, the planes are made. Chances of dural tears possible, but they are very, very less as compared to even tubular discectomies. And yes, the scar is negligible. The disadvantage I feel is, yes, that you need to have all instruments which are specialized for endoscope. For example, in UB, you're using the same instruments. However, for a full interlaminar approach, you need to have all your instruments specialized. So you need to have that initial investment to start doing these cases. So when it comes to regarding the position, when I'm doing a discectomy, I want to open the interlaminar window. So I usually break the table. After positioning between two bolsters, I break the table so the interlaminar window opens up. However, if I'm doing stenosis, I let the natural lordosis be, because sometimes what happens is if you open it up, you'll end up under decompressing in stenosis. So for discectomy, it's always flexed, and for stenosis, I keep the table neutral. This is a typical way. So if I'm addressing the patient from the right side, then as a surgeon and scrub nurse on the same side, my irrigation is towards the head. My light source monitor, my CM comes from the opposite direction, and my RF and burr I generally keep at the foot end. So the difference in transforaminal and interlaminar also is that in interlaminar, once you take your initial entry point, your C-arm is in the lateral position. It also helps you to support your elbow over the C-arm, so your hand doesn't start paining. And in transforaminal, once you dock your needle and scope, your majority, the C-arm lies in the AP position. So the entry point, again, is as I try, and for a discectomy, I try and be as medial as possible, just lateral to the spinous process. And even if the disc fragment is at the disc level or even slightly superiorly migrated, I still try and go through the ligamentum flavum first, and then if required, I do any bony decompression. Once that is done, the dilator is placed. This is a very important step where with the dilator, you check, same way like your tubes, you feel the inferior part of the superior lamina, you feel the medial facet, you feel the superior part of the inferior lamina, you sweep the muscles off, which helps you to do less dissection later on. So this dilator itself helps you to dissect out the area, helps you to dissect out the muscles over the ligamentum flavum. And this is the outer working cannula, which is beveled, and this helps us to mobilize the root medially, as you saw in Dr. Banot's live surgery. Once it's inserted, then you start the case. Again, the difference between transforaminal and interlaminar is, one, yes, you can zoom in, zoom out, and number two, you have the flexibility. So once you dock your camera in a transforaminal, the camera remains where it is. However, in interlaminar, there is a lot of flexibility available, but that makes the execution of the surgery also more difficult. You may look at a surgery and feel, okay, this is very easy, but handling the scope with your one arm, where you are handling the cannula, the scope, your instruments, they all have to go together, otherwise you will start breaking your instruments. So this I have docked directly on the ligamentum flavum, and once I'm on the ligamentum flavum, we make a small rent in the ligamentum flavum, and we start moving laterally. As you see, I'm rotating my cannula to stretch the flavum. You go from medial to lateral, make a slight slit in the flavum. This is all the steps which we saw in the live surgery. And once I'm lateral enough, I see the epidural space down. You need to have a radio frequency. A lot of people ask me the question that can we use normal bipolars with the radio frequency probe? I would say no, because a lot of times these blood vessels are on the nerve, on the dura, and that time the bipolar would say, as you see here, this is right on the nerve. So you need to have the RF cautery to do a job well. And another rule of endoscopy is before you remove anything, please use your cautery. So here the nerve is a bit tight. I see the, the disc laterally. So now I'm using my cannula and I'm medializing the nerve. And once that is done, I'm going to remove the disc fragment. And once the disc fragment is out, you will appreciate how, so initially you were just seeing the lateral border of the nerve. Now the minute this huge disc fragment is out, and once I derotate, I removed almost 3-4 fragments. Now you see the axilla, you see the whole nerve in totality. So initially I could not see the axilla, but because this the disc fragment was removed, the nerve was decompressed, you can easily see the axilla. Again, this is the flexibility. You can go right from pedicle to pedicle using the interlaminar approach. Even for L4-5, there is a decent amount of interlaminar window. I still go through the interlaminar window first, and then I use my burr as and when required. Patients are walking immediately, and this is a 4-day later MRI. As you see, we've removed the fragment. The beauty is that the lamina is completely intact. Even the left side and the right side, if you see, there's hardly any muscle damage. Even the fragment which was sequestrated down has been removed. You can see epidural vessels there. And the ligamentum flavum is also intact. So that white small scar which you see in the ligamentum flavum, that's the rent which we made. So this is inherently, we've hardly removed any anatomical structures. And even on post-op MRIs, if you see, this is a post-op MRI done 4 years later, and there was no mention of any surgery. The radiologist could not pick up that this patient was operated in the past. So I think that is the beauty of these surgeries, where we are not leaving any scar tissue or any evidence that a surgery was done. And definitely with time, you can start doing revision cases, you can start, and once you finish once you master the discectomy, then I think it's a good time to venture into stenosis, because majority of discs are getting better conservatively, but it's the stenosis, severe claudication patients, which usually require more often decompressive surgeries. And if you're not used to operating a discectomy, the stenosis is going to be even more difficult because you are supposed to burr. So I think with lack of time, I will not discuss about the stenosis right now, and I think we'll conclude here. Thank you.